Thank you very much for your kind introduction. It's really an honor and privilege to be here today. Congratulations on a great turnout for Regional Anesthesia UK, and I'm really, again, honored to be here. These talks are really always challenging to give because there's a large audience. You don't want to talk too much about science, but you do want to convey a message that actually reverberates with the society and pays a tribute to who the lecturer is being endowed by. I believe I have 40 minutes for this talk, so I just want to make sure that I time this properly. So, humble beginnings to road ahead is the title that I was given to talk about, and to get started with this, I certainly need to disclose that I have received multiple research grants and compensations for research as well as for various industry-related services. I also co-Avenue V Media, which is a media agency based in New York that does a lot of illustrations and animations you might see in this presentation. More importantly, I have to disclose that I'm beer brewer now. You know, when you move to Belgium, then you have to do like the Belgians do. So I brew now high-end triple and other specialty beers, and it's Mark Knups, one of the my partner in crime and one of the most renowned brewers in Belgium. One of the brewer's name is Admiral. Admiral is actually a butterfly. Butterflies symbolize joy and transformation, which the beer wants to really do. This is the Dr. Blues beers, and hopefully I actually have a couple of gifts here for Dr. Walt Marens and for Dr. Steve, who is just an amazing guy who has offered such an incredible help on the work on our new textbook. So they will have an opportunity to indulge in Dr. Blues brews. Now, what are you going to get in this talk? Well, in this talk, actually, you will see my views on the progress of regional anesthesia, what I think the future will be. I will share with you about 25 plus years in leadership, actually. And I will share with you what I learned from about $50,000 investments in education and leadership communication and winning team buildings. Some of these tips and things that I share, for some of you at least, may actually change your professional, maybe even personal lives. And this is really not kidding, because it has changed mine. Humble beginnings. This is New York City here, and this is the view from my balcony. In here somewhere is the Roswell Hospital, and this is the St. Luke's Hospital, where I spent almost 30 years of service. Now, this is William Halstead, who lived from 1852 to 1934, but in the 1890s, it is this guy who, in Roswell Hospital, the place where I practiced, actually invented or accomplished the first axillary brachial plexus block. So it all happened there. 100 years later, New York School of Regional Anesthesia was founded in the same place, so it was we were gas-free since 1993. And really a lot of things happened in the meantime. Now, one other thing in this road that I really need to mention is the name of great Alan Winnie, who unfortunately died a couple of years ago. But Alan is this incredible individual. If you have never seen Alan Winnie lecture, and you are an aspiring academician and a lecturer, you should go to YouTube and look him up. Once you see this lecturing style, and if you can reproduce that, you will be better than anybody out there. But this is the guy who could actually peel layer by layer of anatomy without ever showing you a slide. But the claim to fame of this man is really simplifying regional anesthesia. He is probably the inventor of the interscalene brachial plexus block, whereby if you placed a needle in one spot in the brachial plexus sheath and you injected one volume of local anesthetic, then you got the interscalene brachial plexus block, which he claimed to be the spinal of the upper extremity. And it really is. But you will see how the history actually went on to become a lot more complicated than that. Today, away from Alan Winnie, we have a lot of these devices. These are high-end equipment that were previously unavailable, not only to anesthesiologists, but anybody. And anybody who claims that there are basic blocks, ultrasound-guided basic blocks, is totally wrong. It's just to operate one of these devices, you need to be an advanced, actually expert. So there are no basic blocks, no matter how you look at it, when it involves ultrasound management and use. Now, what is really very interesting, even though the ultrasound now allows you to see the anatomy, actually the one thing we never managed to accomplish is to decrease the rate of complications with ultrasound-guided peripheral nerve blocks. And that's really kind of weird. How would that be possible that we are not able to do that now when we have such an incredible visualization of the anatomical structures? And maybe this is the answer to it, and that is that now when we have ultrasound, actually we have turned simplicity into complexity, and we actually started playing video games with ultrasound as opposed to using ultrasound to monitor what used to be a simple approach to make sure that it remains simple, but also monitor that we know where the local anesthetic distribution takes place. This video I took off internet, YouTube, and he's a very astute clinician who actually passes the needle to accomplish brachial-plexus block with 10 injections. So what used to be one single injection, folks are now transforming into video games, passing through the stroma of the brachial plexus on both sides. And if you count the number of these injections, I kid you not, you will come up with 10. So what used to be one injection, it has become 10 now when you have a tool to make that one injection successful. Now, if you talk about general anesthesia has always been about safety. This is what put anesthesiology on the map. Some of you may remember or know that back in the old days, the worst surgeons who could not operate were actually chosen to give anesthesia. That was in the early 1900s. Since then, we have become highly sophisticated, and it's really the safety, the ticket that we flew by, that got us to the prestige that we enjoy today. This is the American Society of Anesthesiologists, but introduction of the ASA, standard monitoring, back in 1986, changed it around for us. We became the purveyors of safety and quality. Okay? Now, the American Society of Anesthesiologists has a tremendous emphasis of safety. Here's one example. Check this out. Practice advisory for the prevention and management of operating room fires. Now, for those of you who are younger than 40 years of age, how many of you have seen a fire? I would be very surprised if anybody. I've never seen a fire in 35 years of practice. And they have an advisory for something that happens 1 in 300,000 anesthetics. That is how serious they are about patient safety. How about regional anesthesia? Well, regional anesthesia is more of like, look what I can do. Check me out. Look, I got ultrasound. I can place that needle anywhere. Let's try something. How about this one? This is actually an excerpt from a standard textbook. These authors are actually advocating the use of an intraneural injection, something that is supposed to work for you, okay, in an era where you have instruments to avoid it altogether. And it's become a race. Who is going to invent a new block? The brand new, another Me Too ultrasound nerve block. Well, I bring to your attention the quadratus lumborum number 16. Now, all of these other ones, the 1 and 2 and 3, it's all garbage. Because once you get to 16, then you will know where the truth really is. Well, the folks that invented TAP block made us all practice TAP until they said TAP is garbage. They invented QL1, and then the QL1 became garbage, and the QL2 became better, but not as good as QL3. But I believe that by the time we reach to QL16, we'll be just about at that sweet spot. Now, the French team of anesthesiologists published actually the dangers of the lumbar plexus block. This is in 2005. They had 25 spinal anesthetics, 1 death, 3 seizures, and 1 death. Death rate nearly 1 in 5,000. A near catastrophic event was 1 in 200. Now, if you look at the quadratus lumborum block, guess what's next to it? It's psoas major. Therefore, I really wonder when are we going to see the risks unfolding upon us. Now, this is the vicious cycle in regional anesthesia. Dr. H publishes a case report on successful analgesia with ultrasound-guided Belgian beer block for colectomy. Now, Dr. H is a very charismatic speaker, and he's invited to talk at the RAUK and all other kinds of congresses about this new Belgian beer block. And Dr. H and colleagues now take a case of Belgian beer to anatomy lab and inject it in a cadaver. And in cadaver, they proved that actually beer spreads in all the tissue fascia as what we are supposed to. Now, no one tests the Belgian beer block in randomized controlled trial in patients, but the workshop delegates, at some point in time, I asked it, hey, can you show us how to do the Belgian beer block? And now you have these young, really powerful instructors, and workshop instructors had never done one Belgian beer block, but they embarrassed to say, you know, we don't do those, but I can show it to you. You know, I know where the fascias are, it's easy. Next thing you know, these people actually go back to their practice and they're actually trying to reproduce what nobody has actually studied in patients. And the vicious cycle continues with quadratus lumborum number 17 and goes on and on. Now, there is a very interesting actually communication coming up in regional anesthesia and pain medicine that kind of really sums up or explains this craze about inventing regional anesthesia techniques, whereas in fact there's really lack of effort on making sure that they're proven in clinical practice. What is the solution to the vicious cycle? I believe the solution is really standardization. If we manage to standardize everything, you will accomplish that public and governmental recognition, as opposed to be mavericks that nobody really understands. What is it that we actually do? Now, I will get this started with one example and a short leadership course to those who may be interested in this. But at some point in time, I made a leap to form a regional anesthesia center from New York to Belgium. And basically, we took the Nysora bags of tools and landed in a hospital in Limburg, where we were charged with a task to create a regional anesthesia center. Now, the institution in question here is Zoll of Ziekenhuis Oost-Limburg in Genk. It's East Limburg in Belgium. It's an institution with 800+ beds, major draining institution for large population in Limburg. Patients are Dutch, German, French, Belgian speaking. There's lots of orthopedic surgery, which comprises about 25% of volume. 50% of those outpatients, it's private practice with some loose academic affiliation. And we had at that time 15 anesthesiology residents. So what does it feel like when you leave one institution to go somewhere else and actually create something? But imagine that this is your life. So you'll be writing your life on this board, and there's a lot of stuff that accumulated, sort of like in your closet or in your apartment before you move to another apartment. And then you land somewhere else, and your life actually becomes something like this. You have a clean slate. Now, you can write whatever you want to on this particular board, and it's an incredible feeling, actually. I mentioned this because it will come up a couple of times intuitively in the talk, is that you can change things around only when you change your surroundings. Now, when I assessed this practice, it was in January 2015. Orthopedic surgery comprised about 6,000 patients a year, 4 operating rooms, 8 orthopedic surgeons. There were top Belgian surgeons, actually with international reputation. Some of these folks are on the Belgian Olympic teams, and we treat a lot of international athletes. Large joint replacement programs. There was a mix of general and neuraxial anesthesia. And nerve blocks are mostly were done for postoperative pain. Only about 20 blocks a month or so. There were no standards. Equipment and local anesthetic menus were existing for individual doctors. In other words, when Amit did a block, they had a binder that said Amit on it. And when Amit did the block, Amit likes this needle and this local and this drape and this tray and this machine. But then when Dr. Waldmaren came in, they had another binder for him. He hated his stuff, Amit's stuff. He had his own needles and own locals and own mixtures and on and on and on and on. It was a mess. And you never knew, actually, as you were a surgeon, what your next patient is going to get. As I continued assessing the practice, the patients complained of OR inefficiency, turnover time was slow. Now, mind you, this is not too bad. it was over 20 minutes. But there was an inconsistency and inefficiency and efficacy of nerve blocks, no standardized clinical pathways, and there was no standardized acute pain management. Anesthesia-surgery relationship, fortunately, was actually pretty good. So we set out to establish a clinical practice in about 12 months. Now, for those of you who are changing jobs, I would like to offer one contract tip. But before I offer you that tip, I would like to know how many of you feel that you are not adequately paid. Okay? Well, I'll give you a secret. You know, you don't get paid what you deserve. You get paid what you negotiate. So make sure that you know this, because most of us being doctors, we're not used to negotiating. We think we are professors, we publish, we're great teachers, we come in with a lot of enthusiasm. But folks on the other side of the table will not get you paid what you deserve, only what you negotiate. So take that with you wherever you may go. Now, the step one in establishing a practice is you need to establish a team. And the team includes team building. A team building is not an easy task, but by definition, team is a group of people with complementary skills working together in a committed way to a common purpose. Team members may have individual tasks, but they need to sign on mutually, actually on a common goal and the end result. Together, everyone achieves more. Now, the stages of team formation are a bit more complicated. I won't go to many of them, but when you start forming a team, what you're going to see is there's going to be a lot of excitement. Everybody will be anticipating, and there will be folks that will be very anxious. Will they fit into the team? Is this going to be a failure for them, or they're going to be ousted? And there will be a mix of optimism, actually, and anxiety all along. And eventually, when you start doing this, reality sets in. There's people that are going to be frustrated. You need to be able to deal with them. There will be people who will be dissatisfied. They will eventually start adjusting those who can, but anxiety will remain. Eventually, when you start getting a team together, they share the goals, they start cohesing together, they start coping and accepting what you actually have to offer. And then, when the team is performing, it's a teamwork, it's a cohesiveness, it's a leadership and performance. But it goes on, because as it gets tighter and denser, you're going to see, again, the steps from the forming. Crisis, separation anxieties, and on and on and on. It's really a lot to form in a team. But if you want to form a team, what you really need to understand, it's a very time-consuming and sensitive process. There's a lot of stress in it. And the most common reason why the team forming actually fails is because the manager failed to appreciate how much effort goes into making a team. You can't just make a decision and make a team. It takes a lot more than that. Here's a priceless leadership advice on how to deal with people when you start forming your team. You know, people fall into 4 categories. Every one of you who has tried to actually form something, a team, if there are any salespeople here in particular, this is a priceless advice. But there's 4 groups of people you will be dealing always. And it's extremely important that you recognize who belongs to which group, because how you treat them may determine actually your success and allocation of time. Mother Teresa is the first one. These are people who love you. It doesn't matter. They wear your T-shirt. They have your name on it. Dr. Amit Pava. They will come with banners. You come to the operating room, they'll Pava, Pava, Pava. And what happens here is, because they love you, and these are, hopefully, most of your folks are there. It will be about 60% of them or 50%. Because they love you, you tend to neglect them or neglect them. Just like you come back home to your family that you take for granted because they're there, you're married to them, they're your kids, what are they going to do? Okay? It is actually, this is your basis that provides the most of the support that you need. This is your family. You need to pay attention to them. The second group are the mercenaries. These are folks that are yours for as long as you pay them. You know, if these are surgeons, as long as you provide the turnover times that they like, you're the best ever. The moment you're done, the first time, Amit Pava is the worst of them all. So if you're a salesperson These are the folks that you bribe with your little lunches and dinners. You pay them trip to various meetings and things. As long as you pay them, they're yours. Now, these are hostages. These are people that are yours, whether they like it or not. Who are these people? Well, they may be nurses, they may be anesthesia residents, right? They have to do what you tell them to do. So we don't actually pay any attention to them. Just go to your room, okay? But actually, you should pay some attention to them, because even though they have no option today, they may have an option tomorrow. And the most part or important part of this lecture is that you recognize this group of people. And these are the terrorists. You know, terrorists you can't stop. They will explode when you least expect them. There's nothing you can do to stop it. These are the people that you meet every day trying to convince them that what you're doing is important, and they don't give a damn. These are the folks that if you were a salesperson, you come and you're trying to tell them, oh, can you try this new needle? Can you try this new alter? And eventually, actually, we tend to spend about 90% of our creative time with these folks. They will never change. Well, if you're a salesperson, let them go to Payonk or B. Brown or someone else, because they will be dealing with them too. And if you are trying to form the team, these are the people that I say, man, you have such incredible skills. You know, your cardiovascular knowledge is amazing. You really should be in a cardiac team. Don't spend time with these folks. So this is our team, and it all starts with education. We had on-site teaching, we had weekly workshops, and we brought people from abroad or from other centers, because otherwise you become stale. You know, if you teach every day, you people, and eventually they get bored of you. So you get fresh blood. That way everything gets reinvigorated. These are our incredible nurses who actually teach day in and day out, new nurses, on how to help out with administration of the peripheral nerve blocks. And step number 3 in here is you really need to standardize clinical care. Unless you do this, you basically will never have service. Match surgeries with peripheral nerve blocks is the greatest problem in many university centers. A patient comes in with a wrist fracture, and the attending anesthesiologist says, okay, supervisor, what do we do today? Well, let's do an axillary block. Next day, next time, another wrist fracture. How about now? Well, let's do a supraclavicular. And let's do it low interscalene. Let's do this with dexamethasone. Let's do this with 2% lidocaine. And eventually, a registrar may graduate without being able to make a decision on what to do in a real clinical practice. Okay? So you need to match surgeries with peripheral nerve blocks. Standardize regional anesthesia techniques. They all should be doing it like in the Army. Therefore, we call our training a boot camp. It doesn't matter what you think, you always will do it one way. It doesn't necessarily mean that the way we do this is the best way to do, but if you learn how to do it one way, you can take it somewhere else when you leave. This is what we use in our training, and again, a lot of experts put a lot of time in making these posters, but again, it's not the only way to practice regional anesthesia. But if you do it every day like this, you actually will have an effective training and a shot in getting your service accomplished. We standardize a pre-medication. It doesn't matter what you use at the end of the day, but this is what we use. This is ketamine S, 5 milligrams as a pre-med, and 2 milligrams of midazolam for most patients, 1 or 2. Again, not the best way to do things, but everybody will get this. So there's no discussion what you prepare for the next patient. You expedite things so much. Safety, we use just about everything that is available. Yesterday we talked about nerve stimulation and a value of ultrasound and some sort of injection pressure monitoring. But again, we document everything in a very standardized fashion. Sterile gloves, in plane, 1 injection, open injection pressure less than 15 psi, nerve stimulation, no motor response at 0.5. This is very powerful. If you have all these things together, I challenge anyone in court to label me as being negligent, because I have done everything I could, actually, routinely, to avoid problems or decrease the chance of problems. Intraoperative management is also very much standardized. Okay, they got a regional anesthetic. They have analgesia, and paralysis. But most of these patients actually need to be sedated to the level of comfort, to patient's comfort and a surgical comfort. For us, we use headphones, noise protection, music, and we use a TCI, or target control infusion, at about 0.5 to 1.5 micrograms of propofol. Intraoperatively or perioperatively, everything is standardized. This is not to say that this is the only way to do things, but every patient that undergoes major surgery will actually get this perioperatively in our practice. That substantially, actually, protocol-driven care substantially facilitates the care. Step number 4, you really need to establish a peripheral nerve block room. Unless you do that, it's not going to be possible. All regional anesthetics in our practice are performed in the block room, including spinals. Now, when we started doing this, there was a war. It's not safe to do the spinal in the block room. And when I asked why, well, don't you have to take patients after spinal to the operating room without monitors? Well, my answer was, but don't you have to take them after surgery without monitors to the recovery room? And eventually they said, okay, yeah, you can do that, but please don't force anybody, Dr. Hadzic. But eventually, about 2 months later, see if you can come in to practice in our orthopedic ward without doing spinals and epidurals in the block room. The surgeons will rip your head off because it saves a lot on time. And again, resistance is what you meet a lot. This is what our block room looks like. It's really very, very busy. It's a lot of patients that pass through. Now, make one change at a time. If you change everything, it's going to be chaos because everybody is used to doing certain things a certain way. Make sure you change one thing at a time and make sure that everybody gets adjusted to it and is happy with it before you move to another. There should be no stars. You can be the best guy in the world, but in your home, you're always a schmuck who didn't take the garbage can out. In a practice, where you practice, you cannot be a star. You have to be one of the guys. Everybody's important. But if you think that you're more important than everyone else, remember, no one is irreplaceable. And you've heard stories of many people, you think, oh man, when Amit Pava leaves, it's all going to crash. But actually it doesn't crash. The hospital keeps on going on, maybe not at 100% efficiency, but nothing will really collapse. Step number 5, you need to establish parallel processing. Several things have to be going at the same time if you want our efficiency. Bring everyone on team together, nurses, cleaning techs, surgeons, administrators. You know, I routinely, when I see nurses or cleaning people carry 3 different garbage cans, I actually help them out. Everybody does. There's no stars. This is a very complicated slide that I won't go into, but you actually have to have several different processes going at the same time in order to really make it time efficient. Communicate what you do. There's many different ways you can communicate. I know Amit loves, what do you call it, Twitter. So Amit and Donald Trump are the leader in Twitter communication. But they're out there to make Twitter great again. And as you know, the Twitter, ever since Amit and Donald have taken off on the Twitter has gone up at about 25% in stock. So I'll be buying some more. But communicate. I actually set up in Gmail a gang team, and I select them all, and I pass along the messages that I believe everyone should be in tune with. Otherwise, you'll get members that may feel left out. This is very important, communication. We actually bring consultants. You have to bring consultants because nobody will believe your own results. Amit Pava is making stuff up again. You know, just bring people who are impartial, who can actually evaluate. They can give you also guidance, and your own assessment on progress, yeah, is actually a little bit less credible. These are the results. We accomplish a turnover time of 6 minutes. What that really means, one patient leaves the operating room, another one comes in. It's only 6 minutes. In fact, in reality, it is less, but our commitment now is 6. The utility rate of the operating room is 94%, meaning what happens in the operating room, 94% is surgery or some other work, but not anesthesia work. Anesthesia work time in the operating room is only 7.5 minutes. You can do that by using block rooms. You need to promote what you do. In here, actually, you have, if you can just bring up the volume a little bit.
And enhanced recovery. after orthopedic surgery at Zoll, Ziekenhuis Oost-Limburg in Genk, Belgium. In collaboration with the New York School of Regional Anesthesia, Zoll has opened one of the very best centers for orthopedic surgery in the beautiful region of wooded Limburg, Belgium. This animation is made as a patient's guide to the orthopedic surgery at Zoll. The CREAIR team works together on every aspect of patient experience at Zoll, with the single goal of making your surgery anxiety-free and successful as possible. Upon arrival to the patient's services, you are going to be greeted by our team of nurses, ancillary personnel, surgeons, and anesthesiologists. You will have an intravenous line placed by some of the most skilled nurses in practice. One of our team members will be the primary contact throughout the hospitalization and will transport you to the preoperative area at CREAIR. Here, the members of our orthopedic anesthesiology team will briefly describe the anesthetic and pain-controlling procedures. Before you are exposed to any discomfort, our experienced team will administer our protocoled cocktail of medications that will make your experience of anesthesia pleasant beyond expectations. Our anesthesiologists at CREAIR are affiliated with NYSORA, the New York School of Regional Anesthesia, which is one of the best-known anesthesiology organizations in the world. Its members have pioneered anesthetic procedures, protocols, and safety equipment, and have taught generations of anesthesiologists in orthopedic anesthesia. At CREAIR in Zoll, we employ the most specific techniques of anesthesia administration aimed at minimizing the effects of the anesthetic on the normal physiology and brain function by utilizing ultrasound precision-guided local regional anesthesia. Once you receive an anesthetic, our team of sympathetic CREAIR nurses and anesthesiologists will carefully monitor the effects of anesthesia and explain the aspects of your perioperative care. Throughout your stay, you will be in a bright room with relaxing music being played and will enjoy beautiful views of the Limburg nature through the windows, all aimed at creating a healing energy for your operation. Once the operating room is ready for you, our team will transport you there, where you will be greeted by the operating room staff, selected from amongst the best of the best. As they are preparing you for surgery, the team will introduce themselves and explain what each and every one of them will do during surgery to make it the most enjoyable and successful experience. During surgery, you will be given headphones to listen to the music of your choice to help relax and soothe. You will be administered the minimal medication necessary and will be cozied up by warming blankets to keep you comfortable during surgery. Our NYSORA-affiliated anesthesiologists will administer the protocol medications aimed at diminishing the pain and decreasing the chance of developing chronic pain after surgery. Throughout the surgery, you are likely to be lightly asleep so that you are not aware of the surgery itself. Yet the medications selected are dosed so that you are fully awake and able to converse as soon as the surgery ends. After surgery, you will be taken, awake and comfortable, to the recovery room before your recovery continues in your room. Our surgeons at CREAIR use the latest techniques and protocols to make your surgery the most successful possible. They are among the best in Europe with years of experience and have published extensively on their work in the most prestigious surgery journals worldwide. Likewise, our NYSORA-affiliated anesthesiologists are recognized leaders in clinical care and have published in the top anesthesiology journals and taught generations of anesthesiologists. We look forward to seeing you at Zoll and vouch to offer you the best care possible.
You see, that's a sales pitch. But if you don't do it, who else will? And when we release the stuff like this on a local radio and a newspaper and a television, it is amazing how much local community knows about this. Actually, our surgical volume in orthopedic center has gone up by about 30%. We have been getting patients from Netherlands, Germany, France, and things like that. If you don't promote, who else will for you? Extremely important. So, team building is really a journey. You can change your life, your co-worker's life, patient's experience with it. But 18 months later, we had a top clinical service with 6 minutes turnover time, professional research center, center of excellence in regional anesthesia, ultrasound-guided boot camps, and a sort of Europe RAPM actually fellowship. So these are a few more secrets on leadership that I would like to share with you. Number one, if you want to be a leader, you have to be prepared to take a small calculated risk. In my particular instance, was leaving one successful practice to create another. There's a risk to it, but it's small and calculated. Number two, the sex therapy or prescription for this. If you do something well and you do it for a long time, the success will most definitely come. And this is where the youngsters get really frustrated. They want something overnight, tonight. It really takes time. Do it well for a long time. Focus. You can't be a jack of all trades because you will become a master of none. These are people who want to work with you and they say, what do you like to do? Well, I like a little regional, a little cardiac, you know, if you do that, you actually never will be known or focused on what you need to accomplish. Number four, when the going gets tough, you just really have to remember that if it were easy, everybody would do it. This is the one thing that I picked up from Jerry Vloka, who I worked for a long time, my former academic partner. But every time when I would be frustrated with something, Jerry would say, hey, Admir, just chill. If it were easy, hey, everybody would do it. And it's so true. So in summary, the future of regional anesthesia or road ahead, I believe, is in the standardization. It's not in a high-end, few people with some incredible outwardly skills to recognize certain tissue planes that no one else can reproduce. But it's really in standardizing what we already know how to do so well. It takes a vision and commitment to build a service in your hospital using that standardization. You have to bring everybody on team together and most definitely standardize just about everything you possibly can. Note stating here that maybe your standardization may not be best for every specific scenario, but without it, you will not be successful. Encourage team effort. These are the folks that come in that basically, I do it differently. I don't do it exactly like Amit. Let me show you my way. These people are not the members of your team. These are the terrorists. And you need to recognize them early on because with them, you will never accomplish what you really want to accomplish. Impossible is nothing. Dr. Blues Belgian Brews. Remember, more doctors prescribe Dr. Blues than any other brand. I want to thank you so much. Thank you.
Thank you very much indeed, Dr. Hadzic. I feel totally inspired, and I've already got two questions. Firstly, our cardiac hiring, and secondly, after Brexit, can we still come and have surgery in Zoll? Are we taking questions?
Let me just...
Okay.
It's traditional. This is the Bruce Scott Lecture, and the one award that Admir Hadzic does not have at the moment is the Bruce Scott Award. And this all started in 1982, so that makes it about 35 years that we've been doing this. The traditional award is this quaich, I hope I'm pronouncing this correctly. If you look up Scottish whiskey drinking bowl, that is what it comes to. So it's a quaich, and it gives me great honor and pleasure to present this to our Bruce Scott lecturer, Professor Admir Hadzic. Thank you. Thank you very much. Very much appreciated. Thank you. At least we got something to put in it. So at least you have the whiskey to add to that. Thank you very much.
You can't be general anesthesia. Thank you.
We don't traditionally take questions, or we give the lecturer the option not to take questions, but if there's no objections, if you're happy to take questions, then, and if there is an urgent question, then we can take one.
I'd be happy to take questions either here or over lunch. You know, one of our rotators who did some research with us from Spain, and they shared with me how they deal with the questions after abstract presentations. She said that their instructors are typically, they instruct them that they have one answer to whatever the question may be. It doesn't matter what you ask, they'll just spit it out like professionals immediately. And right after that, they would say, I don't take more questions. So I'll be happy to take a question or two, but I think for the sake of time, we are running a little bit late. I would be happy to discuss over lunch or anything. Thank you.
Thank you very much.